This battle is over, Leonidas. This battle is over when I say it is over.
Hello cataract surgeons, how are you doing? I hope you're doing great. Today I wanted to show you one of my complicated cases where you think that your battle with this phaco is over, but in reality it's still not. So it's not over till it's over. Let's watch this case. This is a 70-year-old male with the nuclear sclerosis and cortical cataract. As you can see, I had some difficult time cracking this nucleus. It took me some time to crack it to tiny pieces. At first the groove was a little shallow, then I deepened it, then I used a stop and chop technique, and then I started to chop these tiny nucleus like to sub fragments, like chop and sub chop, and then like extract, sub chop, then some viscoelastic go into the to protect the endothelium and fill up the bag and create some space, and then cracking this last piece with the phaco probe and the chopper, like going to the equator and then cracking these nucleus pieces, like doing the sub chop technique. I think the reason like I was stressed out and I was trying to finish it up and got excited that at first I had some difficult time on cracking this nucleus and removing it. So at this point I was pretty relieved, and I was thinking that the case is almost over, and I was about to switch to IA probe, and then this happened. Watch again. I'm aspirating this last piece and I'm pretty happy, pretty excited. I'm done with the nucleus, and then this surge happens. The last piece was aspirated, and then the posterior capsule just seeped under that chopper, which I thought I was putting it in a protective position, and then I ruptured the capsule. So the best, let's watch it in slow motion. As you can see here, the best move here is to realize it, acknowledge it, face it, and then do not come out of the eye until you fill up the bag. You don't want the vitreous prolapse through that hole. Putting some viscoelastic while the probe inside the eye, and now you can see it like pretty clear. The posterior capsule is ruptured, and filling up with the viscoelastic, and as you can see the angry image is right in the middle of that hole in the posterior capsule. Thankfully there was no such a great vitreous prolapse, because we noticed it very quickly. This is a very famous complication, like and it happens like at the very last step of removing the final piece of the nucleus. So here, like, we are using the cutter to cut some of that tiny bit of prolapse vitreous, and then using the IA cut mode to remove the cortex, and then we'll make sure that the AC is inflated the whole time. We don't lose the pressure in the AC, so we don't have vitreous prolapse. And then we're gonna open a 3-piece IOL and implant it in the sulcus with the OptiCapture. Here, like, we're gonna load the IOL. The leading haptic comes first, and it should come as Z-shaped, not S-shaped. Remember that S-shape is for stupid, so it's wrong. And the trailing haptic should be free under that metallic probe. And we're gonna dilate the main wound to accommodate this large cartilage and large IOL. A little bit of dilation is enough, and then the leading haptic goes into the sulcus after forming the sulcus with some viscoelastic, as you can see here. And then the trailing haptic would be resting on the wound lip, or at least at the iris plane, so we don't lose it. And then rotating it with the chopper and placing both haptics into the sulcus. Now pushing the optic inside that capsular bag and do the optic capture, and then removing the viscoelastic and calling it a day. So of course, in these complicated cases, it's better to put a suture in the main wound. You don't want any collapse in the AC after you send your patient home. Put a nylon suture in the main wound, and then we will call it a day. Take-home message is it's not over until it's over. Don't get excited when you complete removing the nucleus. Get excited when you put the patch. Thank you.